This PowerPoint presentation on nTMS preoperative assessment has been prepared and is presented by Thomas Picht and Sandro Krieg. Brain tumor surgery in functionally eloquent areas mandates preoperative functional workup to increase safety and efficacy of treatment. Typically, the primary motor cortex and the left perisylvian language areas are addressed. nTMS in combination with tractography allows individualized planning of surgical treatment based on individual visualization of the functional networks. nTMS is the only methodology allowing targeted non-invasive mapping of the brain cortex with an electric field. The underlying principle is the electromagnetic induction, which leads to an electrical current on the brain surface. Modern nTMS systems apply navigation of the induced electrical field in real time, allowing the examiner to follow the mapping procedure on a screen. Typically, the readout is the electromyography for motor mapping and the induction of aphasic symptoms for language mapping. Other modalities can also be applied. Of note, a safety study on tolerability of nTMS in neurosurgical patients, published by a multi-institutional study, has proven the safety of the procedure in this vulnerable patient cohort. A review study demonstrated the comparable accuracy of nTMS motor mapping with the gold standard of direct cortical stimulation. In terms of clinical impact, several studies have demonstrated that routine nTMS mapping before surgery in motor eloquent areas increases the treatment efficacy in terms of extent of resection, as well as a reduced rate of surgically induced new motor deficits. Here, the combination of the cortical nTMS mapping with tractography to visualize the cortical spinal tract is of importance for clinical decision making. The cortical nTMS spots outlining the essential primary motor areas can be used to serve as seed regions to initiate the tractography algorithm and visualize the cortical spinal tract in a standardized manner. This approach is also an important part of a risk stratification model, which includes the cortical nTMS mapping, the display of the cortical spinal tract, including the measurement of the minimal distance between the planned resection border and the cortical spinal tract, and the excitability profile of the motor cortex of both hemispheres. Applying this model in clinical routine eases decision making and leads to favorable clinical outcomes.
NTS language mapping provides another option of non-invasive mapping. It consists of the same coil with reference markers and a head reference to be tracked. A monitor in front of the patient allows presentation of various objects and allows various language tasks to be done. The camera is then used to record the patient at the baseline without simulation and during the exam in order to differentiate the effect of the stimulation. Then various objects as the Snodgrass pictures known from intra-op mapping are presented. The analysis later on leads to a map in which the various colors represent various different language errors such as semantic periphasias, anomia, or performance errors like stuttering. Concerning the accuracy of non-invasive language mapping compared to awake surgery, we analyzed the accuracy in a 3-centric study, and what we found out is that sensitivity and specificity are rather high, but the positive predictive value is low. Yet we have a very high negative predictive value, meaning for neurosurgical applications we cannot tell for sure where language is, but we can tell for very sure where no language is, meaning the corticotomy or cortical resection. Since the cortical part is not the whole truth, and we all know that the subcortical anatomy, especially for large networks such as language, is even more crucial, we use these cortical areas, increase them in order to reach the white matter, and then perform tractography based on the function assigned by TMS. With this function-based tractography, we are able to provide a standardized, clinically applicable tractography of the whole language network. This was also investigated by several works which are actually done in order to assess the risk for postoperative deficit in terms of language or motor decline. The most crucial value is the distance of the lesion to tract, LTD, lesion to tract distance. In the upper row you see surgery-related aphasia and the arcuate fascicle, and what we found out is that we have a strict correlation between the permanent deficit and no deficit and even the transient deficit group. Moreover, we found that patients who have a permanent deficit had a lesion to tract distance up to 7.6 millimeters, meaning patients above this value, patients with a lesion to tract distance higher than 8 millimeters for the arcuate fascicle, and in the lower row also to SLF, ILF, unguent fascicle or front occipital fascicle larger than 10 millimeters did not suffer from a permanent deficit. So this allows you a standardized risk assessment for the patient, which can tell then an objective information for the patient based on a large study as this one. Besides these numbers, it is also very helpful to show the patient during consultation the clinical problem. In pink you see the language tracts and also the cortical areas. In blue you see motor cortex, and in yellow you see the corticospinal tract. In blue is the tumor. And if you see this, you can show the patient accurately why you do your approach from which direction, why she or he might have a language decline for some days or weeks, and why you want to operate this awake. Then in surgery, you also have this preoperative non-invasive data, which nicely shows you with the same colors, and here in blue some additional coloring for calculation function actually. It helps you to guide your stimulation and your awake mapping. You see also the blue line here, which is the focus line of the microscope. And in green, you see the pointer. In the right lower row, you see the intraoperative picture. Further, you can use this information in your head-up display of the microscope. You see here in green the motor cortex, so it's very easy for you to place a grid electrode for motor monitoring. And also your paper tags, you see here in 2-digit tags, cortical calculation function, and in 1-digit tags, you see language. So you have another modality while you do your awake mapping. For eloquent brain lesions in Munich, we do a TMS language mapping, and then we use the language positive sites within the intended resection as a standard criteria, if this is present, to do awake surgery, and TMS is then helping to guide the direct electrical stimulation. If there are no language positive sites within the intended resection, we do the resection asleep purely based on TMS. This is an awake surgery of a left frontal grade 3 glioma. And in this patient you also see nicely how you can track your stimulation probe and how this probe can be guided by TMS. We also mentioned in our article the use of TMS for arteriovenous malformations. In a study of our 2 centers, Berlin and Munich, we looked into the management and we analyzed 34 patients in this, for AVMs, rather large cohort. And what we saw is, in the middle row, that we are able to provide a standardized measurement, an objective measurement of eloquence. So while size and drainage of AVMs is rather objective, eloquence usually is not. So with non-invasive standardized mapping, you're able to make this also standardized and objective. And what we saw here is that 3 patients also got an upgrading in their final Spätzle-Martin grading, while just by eloquence, while most of patients got a downgrading. Well, this is an example how then our workup of those patients looks like. And we will do this even though we might not operate them. Radiotherapy is another part, and an increasing use can be watched at of TMS for mapping for radiation planning. This is standardized radiotherapy, but also radiosurgery. So radiation oncologists do not have direct cortical stimulation or wake mapping. They have non-invasive mapping if they intend to. So in 2 studies we analyzed metastases and gliomas. Here you see the gliomas. And we analyzed if we use the motor maps as an organ at risk. We analyzed how this radiation plan is changed. On the left side you see this for high-grade gliomas, and what we saw is that we have a reduction of the dose to the organ at risk, which means here the motor cortex, of 10 gray, while the whole tumor dose is not changed at all. The same is true for brain metastasis on the right side. So nowadays we see a lot of radiation necrosis, and even patients with deficits. So data is sparse yet, but we know from these 2 studies that compared to the patient, or compared to the planning without any functional data, we reduce the dose of 10 gray to the eloquent area, while we do not change the tumor dose at all.